Good evening, and thank you for joining AMDA's COVID-19 Grand Rounds, Pearls from Your Colleagues. We'll be starting in just a minute.
Good evening and welcome to AMDA COVID Grand Rounds, Pearls from Your Colleagues. I'm Sabine von Price-Friedman with the Washington State AMDA chapter, your host. This is part of an ongoing peer discussion of COVID-19 in the post-acute and long-term care space. I think this is our sixth event. We know our patients and our care teams have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data insofar they are available, or through best practices that our peers have looked on. Those of you who attended, in my mind, the very memorable AMDA Grand Rounds last week on how to support our staff, it closed with a plea from the geropsychiatrist, Dr. Leah Watson, to ease lockdown in our facilities, to ease loneliness and separation of our most vulnerable elders from their loved ones. We have learned one of the most effective tools how to keep COVID-19 out of our facilities has a steep price. We've learned to keep our patients safe in a closed environment. However, as the country is relaxing restrictions, we are moving to a different environment. This week, our Grand Rounds will focus on the reopening of nursing homes and address the shaping of policy around reopening, along with the challenges and considerations that clinicians need to keep in mind as their facilities open to visitors and some internal restrictions are relaxed as well. Let's talk about three important questions whose answers drive the successful shift to a more open environment. What activities need to be met in order to relax restrictions on visitors and communal activities? What conditions? How do we communicate our expert guidance to those who formulate policy? And what are the most important tools we created and behaviors we have learned that we can use moving forward? How can we continue to provide benefits of keeping patients safe while easing suffering created by lockdown? To discuss this emerging situation, we are very pleased to have three distinguished colleagues join us today, and I'm going alphabetical. Dr. David Polikoff of Massachusetts is the Executive Director of the Center for Health Innovation and Quality and Professor of Population and Quantitative Health Sciences. That sounds very erudite, and I don't even know what that is, but, but most importantly for our discussions, Dr. Polikoff has been, via his faculty appointment and work with the University of Massachusetts Medical School, has been intricately involved in state policy development as far as long-term care is concerned. The next speaker is Dr. Ritu Siru of New Jersey. She's a geriatrician, nursing home medical director and physician, and very involved in palliative care as well. But she has helped develop a policy for New Jersey on reopening nursing homes, which is really a success story, and we want to hear more about how you've accomplished that. This reopening may be a model for national guidance. And Dr. Kathleen Unruh of Indiana, and so I'm giving all the states so that you know where they are at and how bad it's been, is a geriatrician, nursing home physician, and an associate professor of medicine at Indiana University, and a scientist at the Center for Aging Research in the Regenstrief Institute, as well as principal investigator for the Optimistic project. Dr. Unruh has also been intricately involved in policy development around COVID-19 and reopening. As it has become our custom, we want to start out with a poll and see where you are all at. Erin, could you start the first poll? What conditions need to be met in order to relax restrictions on visitors and communal activities? Community state is in phase 2 with low or decreased COVID activity. Facility has sufficient PPE and is not on an emergency plan. Facility has access to testing. And facility is COVID-free for 14 days, or all of the above. Go ahead and vote. All right. I think everybody can see the result of this poll, and it is as I had hoped it would be. I think there is a large amount of consensus that multiple conditions need to be met. The environment and PPE testing, and of course being COVID-free. I want to start out with Dr. Polakov. What do we know about the evidence? And so this is what we think, but what do we know about the evidence that can prevent a resurgence of COVID and long-term care with reopening? That's the hardest question, and I'm giving it to you.
Well, it's a big question that we could spend the whole hour on, but we won't.
Cool.
And on the other hand, we could also answer it really quickly. The
Yes, I know.
is incredibly thin regarding how to respond to COVID in skilled nursing facilities, right? One of the things you and I were chatting about earlier in the day today is that we don't really have very much evidence, and to the extent that we have evidence that is being relied upon, it is largely being extrapolated or ported from other settings like hospitals to nursing homes. And so we really don't have a lot of evidence. You know, I'll make one comment with respect to one of the options on the poll, and one of the conditions that is not necessarily being met here in Massachusetts is that the facility has to be COVID-free, because, you know, over the course of this discussion, I can offer some insights into what Massachusetts has done, what seems to have been well done, and what not so well. But one of the things that was done was the state stimulated facilities to either set up COVID-only units and make the rest of the facility COVID-free, so segregated units for those patients who had tested positive, or in some cases, 12 facilities in the state with state support became COVID-only facilities. And so those facilities never stopped taking admissions. They were taking admissions all the way through. They were taking admissions knowing that they were COVID positive, but they were putting them in COVID positive environments. And so if you go to, you know, the facility being COVID-free, then, and they're in that state, then they could never get to reopening. So it's a little bit of a logical inconsistency.
Mm-hmm.
So, you know, that's a
Can
little
I
bit.
ask a follow-up question?
Some of the others, I think, you know, it's very clear that we need adequate testing, but we need there's a lot of debate about what adequate testing is. So for instance, is surveillance testing weekly, daily, biweekly? Is it every resident? Is it a sample? Is it all staff? How often are the staff tested? So testing, there's still not a lot of evidence, and I think there's a lot of finger to the wind. We think it's about this, and you know, it's very clear that we do need adequate PPE. I mean that.
Yeah. Let me stop you right there and ask another follow-up question before I go to the other panelists. So I'm interested in the COVID-only facilities. We don't have those in Washington. We have some that take COVID, but not COVID-only facilities. Are they restrictions for visitors? Because in those settings, you could argue, I'm not concerned about COVID coming in. It's already there.
I believe they did still have restrictions for visitors.
Okay.
No, there weren't that many facilities that stepped up and volunteered to become
Okay.
COVID-only facilities. We have about 360 in the state, total facilities in the state, and 12 COVID-only.
Okay. All right, thanks. Dr. Unruh, do you have anything to add?
Oh, so the only policy we have around visitation is for outdoor visitation. And what our policy says is not COVID-free, but no new COVID cases that originated within the facility. And so if it was the case of a transfer kept on a COVID-only unit, that wouldn't preclude them from having transfers.
Okay. What about you, Dr. Suri? How did you approach the issue of being COVID-free, having to be COVID-free versus more a nuanced approach that Kathleen, and I'm sorry, Ritu, how did you approach that?
No, we also did only new COVID cases that were facility originated, whether it's staff or residents, but it was facility originated, not patients coming in with unknown status or COVID positive patients coming to the facility. They were designated to a separate unit. That's how they did it in New Jersey as well.
Okay, and so how long did was there any time frame that you had that the facility couldn't have any COVID positive patients?
So the units that we had the PUIs, which we call the person under investigation or a new admission where we were not sure of their COVID status, that was 14 days of quarantine. So those patients were not allowed any visitation. And we are only going into our phase 3 of visitation where in those facilities, there's no COVID, like facility originated COVID positive cases for 28 days. So they haven't had, so they had a phase one of 14 days and a phase 2 of 14 days. So it's total of 28 days now that they have now no new cases that originated in the facility.
And you have some COVID patients, I take it then, that have potentially been in the COVID unit for longer than 28 days?
Oh, absolutely, absolutely, absolutely.
We do. With those. Yes.
Absolutely have.
Okay.
Absolutely. Yes.
Well, so I think what you're showing us is two incubation periods here, basically.
Absolutely.
Your guidance, and I think so. That's possibly the best evidence we have for that. Any other comments on the access to testing or testing? We've talked about testing before, but let's give it a quick review here. I can tell you that this morning I was in a governor's committee where many stakeholders in the government were present, and myself and the Healthcare Association. And they have a complete testing plan. Nobody was asked from those who actually do the testing and actually take care of the patients. And then they said, yeah, we are thinking about retesting, but we can't tell you yet. And they're like, okay, well, why don't you incorporate some of us who do the testing work and who actually see the patients? So how did that retesting get answered in your recommendations?
So we were, like what happened was the New Jersey government came out with a guideline, and they actually came out with a regulation that we had to do surveillance testing on every resident and every staff. We needed a baseline on every resident and every staff. And then everybody needed to be tested. Now, everybody meant what the facilities took it as everybody that was positive already, they were testing them every week as well. So there was so much angst around the whole thing that we finally took it upon ourselves as medical directors, got together, and we created a guideline for the facilities. We approached our ex-health commissioner, who is an internal medicine physician, reached through her to the Department of Health and actually submitted our guidelines to them. And then, we created a little clarity on surveillance testing versus testing for cure if you wanted to pull somebody out of the COVID positive unit. So there were two things that people were completely missing and mixing together. So we kind of, try to separate it out for our facilities. What is surveillance testing? Why are we doing it? What is the goal? Our goal is to be able to open the facility eventually And we don't have to keep testing our COVID positive patients already, again and again every week. But they're not giving us any more information for our revisit opening. So I think that was a big breakthrough for us. We were able to get to the DOH, and that's why we worked on the reopening guidelines. We said, okay, this is where we want to be, and we really want to be on the table because it doesn't make any sense to create so much confusion again.
Yeah,
So.
yeah. Dr. Onru, tell us how you approached the testing question in your work.
Well, I can share what Indiana is doing with testing. Well, right now, so we have 534 facilities in the state of Indiana, and the state government is testing all 58,000 nursing facility staff over a couple-week period, Monday through Saturday. Every facility was assigned a day, and they bring tests and leave them for 24 hours. My facility is actually tomorrow, so I'll be in there tomorrow morning getting tested as well. All contract staff, but they also, all employed staff, but they encouraged all the providers and other contract staff to be tested. So they're going to use the results from this, as well as a point prevalence study that was just completed in Indiana, to craft policy around ongoing staff testing. The reason I'm involved is because I have a startup business related to some of my research work, and got connected with the incident command lead in state government for nursing homes and assisted living facilities about 8 weeks ago or so, and we have a contract with them. And so several of my nurses work side by side with our state Department of Health to call nursing facility staff or nursing facilities and assisted living facilities across the state. And then we've also got involved in calling test results, and now with the staff testing, helping with that effort and helping coordinate that mammoth effort that the state is sponsoring right now. And then again, because of those regular contacts and calls, I've been involved and have pulled my geriatrician colleagues along with me in reviewing and contributing to policy.
And of course, the reason testing is so important is because it does really give or shut down opportunities for visitation. How do you relate testing to visits?
So,
Anybody, how does testing staff and residents affect the right to have visits? I think we covered it already, but I think we want to make a real good point here that.
So we are testing the staff every week for now until there is no new cases amongst the staff. Okay. The residents underwent the first testing, like everybody was tested, and then they are only being tested if they show symptoms or there is any change in status, or if the staff that was serving them is positive, then they are tested as well.
Okay. And so then if there's no positive staff, then we can open up.
Absolutely.
No positive, so that, I guess that's what I wanted to get to. No positive staff, no positive COVID patients in
the facility.
Yeah, and then it's time to reopen. And I think you all have talked a little bit about how you were able to get to provide your expert guidance to decision makers in the state. I'd love to hear whether you have any tips for us, for those of us who are trying to get the foot in the door and are us on the way to success, but maybe not quite as far as you have gotten. David.
Well, Sabine, if you attended your governor's committee this morning, it sounds like you already have a foot in the door, but I'm still happy to offer a few comments. In Massachusetts, the reopening, there is no reopening plan yet. The reopening committee was just formed, and it has met once, so it's really just getting started. A group of us geriatricians discovered that there were no clinicians on the committee, and we started making a lot of noise and eventually got to two two geriatricians who practice in nursing homes appointed to the committee. So that was a big step forward. It hasn't done anything yet. However, there is a learning I'd like to offer, which is the fact that the geriatricians in the AMDA community haven't necessarily been invited to the table doesn't mean that there isn't activity going on. And as we started making calls and pushing, and we too have an excellent health commissioner who is, here it's called Department of Public Health, who's an internist and has spent her career dedicated to the homeless community. But she's not, she's not a nursing home person. What we started discovering was there were committees meeting. There was a lot going on. We just hadn't been invited in. And the state policymakers turned most prominently to the trade association for the owners. Mm-hmm. And so we have been able to get some of our members, some medical directors appointed to the committees within the trade association.
Okay,
so we've gone that. In other words, and there have been some other parallels. The Hospital Association also has very active internal policy discussions going on, and they are well connected to state government. And there wasn't any nursing home representation on those committees, and so we were able to stimulate that and go there. So I think the main point I want to make in response to this question is, don't assume that just because we haven't been invited, there isn't already activity. And start to find out where it is, and that's the door to start pushing on to get open to crack. Push on the doors where things are happening.
Yes, and you have to find out about it, so you have to be connected. What about Dr. Kathleen? What is your tip? I think you make a very good point, David. There is a lot of stuff going on and we have no clue. And we have to change that, don't we? We really have, and COVID is our chance. So Kathleen, do you have anything to add to that?
I mean, I think the trade organizations and then the larger owners in the state are used to having a lot of dialogue with state government around a number of issues, and that has certainly continued. And so they are, they're good allies, and they're looking for all kinds of clinical guidance because they're fielding calls from their members. So having already had strong connections with those industry stakeholders has really facilitated a lot of the discussions, because I have a lot of opinions about some of this guidance that's being developed, but a lot of it really is about operational issues that the owners and the administrators can answer better. So it really is collaboration. We need to be there as clinicians, and we need to work in partnership with the industry who knows the resources it takes to get things done. They have different, the tests cost $60 to $100 each, like there's a lot of real considerations to how to get these things done. So I think those partnerships and those relationships, some of which I had through a large stakeholder advisory board for this long clinical demonstration project, and those have just been invaluable and made it more effective.
Mm-hmm. Ritu, what is your advice?
So I'll tell you what happened in New Jersey. That we were one of the states that was really hit hard, and especially in the nursing homes, and very early on, just like you. But the individual medical directors and most of us are CMDs, we actually got really, really upset because we were like really scrambling to get tests. We were scrambling to get PPE. We were scrambling to be able to provide the care at bedside. So we individually and collectively reached out to anyone that we knew, the congressman. I reached out to the Attorney General's office. And then eventually we heard that Attorney General's office was responsible for doing the investigation into the nursing home. So I kind of, really pestered them, did not hear from them for almost a month and a half, but I did not give up. I made a call almost every week. And finally, we all have a place on the table. We are meeting with them starting next week. Once a week, we will, our AMDA members will be on that table with the Department of Health formulating these policies, and it is not going to happen without us this time, especially for the nursing homes. That we made clear, very, very clear with them.
Well, congratulations.
Thank you.
Like
Yeah.
persistence pays off also for your group, David.
Yeah.
I listened to Dr. Lynn the other day, and of course she is I want to say, dare I say grandmother, or she's a very motherly figure for my generation. She's been there, done that. And she said in this Zoom meeting, she said, you have to have the courage to be annoying. And,
Absolutely.
and I found that such a true statement, because I often feel I annoy people, but it's paying off after a while. It's not annoying, or if it's annoying, it's not about us.
It's really not about us.
Yes. So the patients will win, even if we are annoying. I don't like to be annoying, but sometimes we have to be. So I think that it sounds like using your connections that you have, being persistent, and also offering benefits probably here. I can help you with this. And then really utilizing the partnerships. That is, I think, another one, really the health associations, because as you said, they have operational expertise that we don't have so much. So I think pulling all of those levers will get us a seat at the table. We have one audience question in regards to PPE, and I think this is a good segue into our next part of the discussion. And that's more the how-to about reopening, and how does that look like at a facility level. So Jason Spalding, hello, asked, what are your PPE requirements for visitation, both for patients and visitors? Insofar as you have, and I think Dr. Unruh, Kathleen, you have a visitation, and Ritu, I don't know whether you have that implemented yet. What is your PPE requirement?
Mask wearing for all, face covering for all visitors. And again, we're only outdoor yet. We're not at the next stage. And for all residents who are able to wear masks, the recommendation is wearing masks, unless the resident is recovered from COVID. And in which case, then masks are recommended, not required.
Okay, for outdoor visits. Okay.
I don't know if that's actually written in there, but
you make a distinction between cloth masks and medical masks.
For the purposes of family visitation, I think it just says masks and face coverings or face.
Yeah, it is. It could be a cloth mask too. It could be a cloth mask.
In Massachusetts, it can be either for the visitors.
Yeah, exactly.
Staff are required to wear medical masks.
Yeah.
No cloth masks for staff.
Yeah, and I think possibly the goal is it possibly goal oriented? So really the goal is not that the family doesn't get infected, but that we don't get infected from the family, for which cloth masks are good.
That's correct. That's fine. Yeah, it's only the administrative staff can use the cloth masks in the facilities.
Okay. All right. Well, that gets us to our next poll. Erin, if you could pull up the next poll. Erin? So Erin,
that's not showing up for some reason. I'll try to get that to work.
Okay. All right. We'll give that one more second, or then we're going to go. Up, here you go. This is our second poll. What concerns you most about opening your facility to visitors? Fear of outbreaks caused by visitors infected with COVID? Dedication of staff time to facilitate screening and monitoring of visitors? Or concern that families won't comply with safety protocol? Go ahead and vote on this. Okay, we have it in. It's fear of outbreaks caused by visitors infected with COVID is the biggest concern. And then concern that families won't comply with safety protocols, I think, is a related concern. So I think let's talk about visitors. How have you designed your protocols regarding visitors? And I think, Kathleen, maybe we start with you in this one. You already mentioned that you have some safety valves here in regards to visitors. So once the conditions are met to let visitors in, what is the first step?
So, I think there are a fair number of steps to operationalizing it. So for outdoor visitation, there's certainly differences among facilities about how their space, how they're able to accommodate that. In my own facility, which day 14 from our last positive case was yesterday. So yesterday were the first family visits at my facility. And there's a lovely courtyard in this urban facility. However, you have to walk through the COVID unit to get to it so that it cannot be used. So there are a couple tents set up in the parking lot with, some chairs and folding tables and some chairs. And that's, what we could do to kind of get it off the ground. But, it's just, I've heard a lot of positive feedback just in this last week and a half that this has opened up from people who have, been able to see their loved ones that they haven't been able to see for months. It's really, even with the mask wearing and the social distancing and the limited time, it's really bringing people a lot of joy. So it's worth the work. I actually, on the poll, I put staff time because initially, like when you're just kind of getting into it. You did too? Yeah.
Yeah. Yeah.
To do this well,
Yeah.
I feel like it really takes a real investment of staff.
Yeah.
Someone's got to get this scheduled.
Mm-hmm.
Someone should really call these family members and prepare them for what it's going to be like, what the rules of the road are here. And then once someone gets there, you have to facilitate that. You have to get good contact information. If there are positive cases, you need to be able to do contact tracing. You need to kind of run them through the protocol, and actually our policy says you have to offer alcohol-based hand rub, and you have to make sure they have their face covering. But then also staff have got to get that resident ready and get them there. And then you got to monitor this visit somehow and be available to offer support. And what I'll be curious to hear, and I'll ask when I'm at the facility tomorrow, is especially for these first visits, for people who haven't seen their mom for months now, follow up after. I haven't heard that yet, but I'm curious, if someone looks, different, has lost weight, just looks different to them, are they going to have a lot of questions, and is there going to be a need for staff support to follow up? So I've been thinking a lot about the logistics of that, and also helping my independent facility who's, had to create these protocols to get this rolling.
So so thank you for that answer. I want to ask some more questions because I think you assume that we know more about those outdoor visits than we do. So tell us a little bit. So I glimpsed a few things. So it's outdoor. We don't know, is there a social distancing guideline? I hear there's a schedule, how many visitors, how have you organized that?
So the actual guidance says a schedule of visitation hours must be established. Adequate staff must be available to help and to clean afterwards. You have to screen people for symptoms, and you have to have enough PPE for your residents. So the residents need a surgical mask, and then the visitor needs a face covering. And it says social distancing, at least 6 feet between visitors and their loved ones. Is what it says, and then you can additional criteria as needed. So it's really how many people can you accommodate at a time? How long of visits do you want to allow? And I believe so our visitation hours are from 1 p.m. to 6 p.m. and they're 30 minutes. And with time in between for cleaning and turnover, and they're only doing 2 stations at a time right now, because
So 2
again,
stations at a time. How many visitors at a time?
so that would be families, right? I'm not sure. I think
No,
I
we are
think
doing 2 visitors only. 2 visitors we are doing only. Yeah.
I saw an assisted living facility in Indiana's policy that was saying no children under 12. Just I think because of being able to kind of control the space and all of that. So there's a fair amount of discretion there for the facility, as I think is appropriate, because we're working with different environments and different staffing needs. But that's what we have so far. And what I've heard is those spots are filling up, that our families are eager to see their their loved ones. So.
So are you quoting from Indiana guidelines? You were
Yes,
quoting.
yes. So this is our outdoor family visitation at long-term care facilities. That's what I was looking at. So there's social distancing, the face covering, that's all from the guidelines. And then how our facility operationalized it is based on the space that we have, and what we felt comfortable, we could manage safely.
And we'd love to have those guidelines so we can put them on the AMDA website, and I want to put them at my chapter website as well. And then sounds like, David, you got some documents there you can use when that committee finally meets.
Yeah, I'm sure there are, and we've been looking for them.
Yeah.
I do want to add that I voted the same way Kathleen did on the poll. That my greatest concern is about staff time. And one of the reasons is that what we're hearing from our AMDA members across the state in our chapter is that they remain extremely concerned about staffing levels in the facilities. It's just staffing is always a problem, but it's become a much, much bigger problem for a whole range of reasons in the COVID era. First of all, we've had a lot of staff out sick. So staffing dropped. It's harder to recruit in this environment because people are afraid to come work in an environment that has gotten a lot of publicity as being a hotbed of the pandemic. And our state, one of the things our state did very well was they listened to owners early on around staffing and recognized early on that this was a problem, was going to be a problem, and they've taken a number of steps to try to help, but it still hasn't solved the problem. So the state has been out-of-state funds paying a signing bonus for anybody who will take a new job as a frontline staff member. And it's being paid by the state, not by the facility. They're offering essentially hazard pay differentials, hourly wage differentials, to up the wage for anybody who's working in a patient care role in a skilled nursing facility. So it's nurses, CNAs. The state has funded a recruiting agency, a staffing agency for any nursing facility that wants to use it, and the state's paying for it, again, to try to bring in staff. Massachusetts, the state has thrown a ton of money at this problem. And a lot of it has been really good stuff. And right now I'm only talking about the staffing side. They've done other things as well. They've not been unwilling to put resources behind the effort.
Yeah.
The only thing they haven't done is listen to the medical directors about what would be the best way to use it. And I'll just mention one other. They also funded basically a 50% supplement to the Medicaid rate for the COVID era. So the Medicaid rate has been increased by 50% for the COVID era, with one element of accountability. They put forward a 28-point infection control checklist. And in order to get the money, the facility has to pass the 28-point inspection control checklist. And they started sending out auditors to audit the checklist weekly to every facility. And if they passed, they started backing off. It would be every 2, every 4. If they didn't, they're back next week. And you have an opportunity, if you fail, you have an opportunity to correct and recover the funds. But if you fail repeatedly, then you don't get the extra funding. So this is all really good stuff, except they never ran the checklist by a geriatrician. It came from—
I was just going to say, tell me about that checklist. Or
it came from hospital epidemiologists and infectious infectious disease people. It's not terrible. It's probably 80% directionally correct, but it was only after a bunch of us started saying, listen, you got to, this isn't quite right yet. Good idea, but can you listen? That now they're doing some fine tuning and they're improving it.
Okay, great.
That is
I'd
wonderful.
like to hear from you some more about your outdoor or whatever visitation you have actually allowed.
Yeah, so ours is also outdoors so far. And again, it's 2 visitors only, but again, staffing requirement because the staff needs to screen the visitors for, symptoms and make sure that they're having a face mask on. Also, it's a supervised visitation right now, that they're maintaining social distancing. Their hand hygiene is a big issue. We, again, have not allowed children who are not able to keep the face mask on or follow, directions for PPE or keeping a social distance. So I think that is basically what it is. And it is very time limited. It's 30 minutes. Again, we are also first calling them, explaining them the protocol on the time that we schedule the visit. Then you kind of have to screen them again, when they come in, and make sure that you follow the patient after as well, because you want to make sure that they're not having any symptoms, after the visit has been over for the next. So contact tracing becomes like a little bit, you take full information for the visitors. You kind of, some facilities have gone that far that they're only allowing supervised visits. One individual, so that they know who is the individual that is visiting them every week. And but we have allowed 2 visitors, any family members it could be. So
can I just piggyback? We are investigating a question from Charles Crecelius. We are investigating the use of volunteers for outside visits if COVID tested weekly and trained. I'd like you to discuss that. And unfortunately, I have to step out for a second.
No worries. I'm sorry. I need to know the question again.
So it sounds like
Volunteers.
using volunteers to help facilitate visits if they are tested weekly.
And if they're outside.
Yeah, I think, as long as the person knows the protocol, is able to guide, social distancing, hand hygiene, making sure that everyone is wearing a mask, whether it's the visitor or the patient, I think we could definitely use volunteers. Absolutely. Absolutely.
I agree. I think it makes a lot of sense. Just conditioned on proper training, testing
Absolutely.
for the volunteers, and having PPE available for them.
Absolutely.
I think it seems a perfect way to use volunteers. I have another good question from Anonymous. Do the visitors have to be COVID negative to visit? Like when
I was gonna ask.
What about that?
Opinions about this?
Yeah.
So no. They're screened for symptoms, and they're asked, you're asked about symptoms, but no, we are not asking about submitting a, evidence of prior infection, but it's been a hot topic. I think there's a real equity issue with doing that. Unless I've been involved in some conversations about, wouldn't it be great if we had the rapid testing, a reliable rapid testing machine, someone could sit in a waiting room, for 25 minutes and know that they were COVID negative, we'd all feel great. But I don't think that those resources are realistic or available. And also I'm wondering, and I don't know if you guys have opinions about this, about having a facility test visitors that they have neither a treatment relationship with nor an employment relationship with. So I think if you don't do it at the facility, asking people to present evidence for it, there's equity problems with that. And then I think if you do it at the facility, there's sort of resource and potentially other complicated questions about it. So we have, because of those barriers, that hasn't been a part of the visitation. But like Chuck Gracilius's question about the volunteers, who are sort of more like acting as staff, like they'd be there regularly. And so the idea of having them tested regularly like you would have staff tested. That's similar to another policy guidance that Indiana has implemented around essential
Workers.
caregivers.
Mhm.
And for that policy, which again, I haven't heard yet of people using it. I've been asking, but it's a pretty new one in Indiana. But that is for the family members who prior to COVID were in the building, 3 times a week, helping with meals or helping and supporting in that way, that they would be able to resume that type of activities for that population. And one of the stipulations that's in there is that they present a negative COVID test and that they are tested weekly or as often as the staff are.
It's the same that we have, for like hospice staff coming in, or hospice volunteer coming in, or a hospice aide coming in. They need to be tested weekly as well. That the facilities are requiring them, if they're providing personal care and they are still close to the patients, they are requiring them to be tested weekly as well by the agency, by like the hospice agency, or by another agency that they're sending the private aid in for the patient. So that is a requirement that a lot of the facilities, and New Jersey is requiring them to. Yeah.
So one of the issues with testing that we've been seeing in Massachusetts in recent weeks is that while the number of tests available sort of in the aggregate at the macro level is pretty good, there are lots of tests in the state. The National Guard has backed off its role of doing the testing in nursing facilities. So, and a lot of the facilities are having trouble getting their labs to come in often enough. So what used to, it is an issue both for COVID testing and also just for general lab work. So many of the facilities are saying their labs are telling them they'll only come for blood draws twice a week.
I know.
Rather than daily. Because and one of the reasons there is the labs don't have enough personnel or don't have enough PPE for their personnel, and without PPE, it's not safe for the techs to come into the facilities, and so it becomes this vicious cycle. So even if you wanted to do things like test visitors, there's not enough testing available, and it's not timely enough. So there's a lot, it's almost like part of the supply chain for testing that still hasn't been worked out. The test kits are there, the labs are there, but the whole chain of how you get it done isn't timely enough.
Yeah. So this is where I have some hope for the future. That, if you think about where we were 10 weeks ago, nobody could get tested unless you, went to the wet market in Wuhan. But look at where we are now. And I have some hope that, there's a new antigen testing out. Now, it's not as sensitive, but at least it's something. I have some hope that maybe we will make some strides in that we get more in rapid COVID testing, maybe in a couple of months, possibly by the time flu season comes around. So I think there is always a hope that we will develop better, quicker point of care testing that can be done in an efficient manner and not too expensive. Rita, I have to ask you though, you talk a lot about the staff testing and how it's done weekly. What we have found, I'm also a chief medical officer of a corporation. We have found if we were to do that for all our staff, we're not by no means huge. We have 50 buildings, which is big, but not huge. It would be like $1.5 million.
Probably, yeah.
There's no way we can afford that. How do you guys afford that in New Jersey?
Yeah. That is the biggest question. That is why we went through this whole testing process and guideline. That is what the regulation came out of New Jersey, that everybody needed to be tested.
Yeah, but
how do you get the funding? And New Jersey wasn't giving any funding. Massachusetts is great. I'm actually writing all these points down because we have a meeting with DOH. That is phenomenal what Massachusetts has done. New Jersey is nowhere close to any of this. Believe me, I'm out of several providers, several owners who have multiple facilities, it's in the millions, that the amount of testing material that you need and sending it out. So what they have done is, if hospices are looking to come in, then the hospice has to do the testing for their own providers. If the private agency wants to come in, they have to provide them with the testing. Their own staff, they have are left with no choice. So if in the phase 1, they were testing every week, and now they have not had any cases for 14 days. So if you read our testing guidelines, we recommended to the state to change it to at least every 2 weeks, because every week is just phenomenally expensive. We recommended change it to every 2 weeks until they come back negative. So we have tried to tweak that testing guidelines as well, because it is phenomenally expensive, and they have not had any support from the state.
So one of the things we were talking about, I was talking today with my testing group that I'm not part of, I guess, is pool testing. So I guess you put a bunch of testing together, and then if it's negative, then like 10, 20 or 30 people were negative, but if it's positive, then you have to retest everyone.
That's
but
correct.
That may be, and then I think Indiana, or I don't know whether it was Indiana or Pennsylvania, has also looked at random testing. Once there was a negativity, or there's using sort of more cost-effective, possibly doable, not necessarily equivalent, but more doable possibility. I have one question.
Any staff who have had COVID-19 are excused from testing. That's what we're doing in Indiana, at least this wave of testing.
Yes. I have a question from Milton Little. I got that question, that I want to get that in because I think it's an important consideration. She asked us, anyone on the call have experience with creating a plexiglass or similar material structure for safe visitation by families while maintaining physical distances? If so, has anybody run into issues with the state? Because apparently that has been an experience in North Carolina. How do you all feel about plexiglass?
They've already had window visits, and I think they're so tired of the window visits that I don't know if they're really looking forward to a plexiglass visit right now. I think they're really looking forward to seeing each other in person. We really didn't consider it because we've done a lot of window visits in the last 3 months. Everybody was having a window visit. So that's pretty much a plexiglass visit. We really didn't consider it. I think everybody was just dying to meet their loved one. And what we were seeing was when patients were going out for dialysis, when patients were going out for dialysis, the families would come out and, want to meet them or see them in the parking lot. So we were seeing a lot of that. And it was pretty hazardous at that time. And we were really we were having to supervise that. So I don't think so they would have been ready for plexiglass at this time.
Yeah.
Back to your very first question, Sabine, I don't know that there's any evidence on use of plexiglass in healthcare settings. We're seeing it in retail, right, to protect cashiers. We're actually using it at the medical school a little bit in the workplace, like where as they start to bring research, wet labs back up, if the stations aren't 6 feet apart, they're using plexiglass to try to separate people in the workplace. But I'm just not aware of any evidence of using it in a healthcare setting. And for the reasons that you just said, Ritu, as well as the lack of evidence, I'd have a hard time with that. It also almost just feels like you're putting the patient in a bubble.
Yeah.
What are we trying to accomplish here? To come back to where we started, trying to encourage meaningful re-engagement.
That's correct.
connections. And I didn't see the whole comment that flashed up earlier, but I saw there was an analogy with, visiting people in jail, and we don't want it to feel like that. And that's my concern with that. So I know some facilities have played with it, and you've seen like I've seen pictures of it of like, the arms are in the hug, but they're in the, plastic, but then how do you clean that? And so there was one assisted living facility that built one of those and then didn't know how to clean it. And so, people are trying everything they can to be creative, but drive-by parades and window visits are what we've had. And what we're talking about now is what's next. And we're not normal, but how can we get closer?
That's correct.
Now, this has been a great discussion, and we have just a few minutes left. And I want to take, and I've learned a lot, and I hopefully also our stage chapter is fully planning on annoying themselves into a reopening discussion. I think we've made some strides, and have gotten a lot of good ideas. If you could send us your guidelines so we can put them on the website, that would be great. But I want to finish up with one question, and that is, how can AMDA, or how can the community of long-term care professionals help with future visitations? What is it that you would like to see? How would you like to be supported in either developing policy or just doing hands-on medical directorship work and implementing policy? David.
Well, one thing I would really like to see, and we spoke about this a little earlier, was, we've referenced several times that we're doing this all in an almost evidence-free zone. And so what we have, as every state develops its own reopening policies, and there are variations in those policies, and then there are variations within states, we have a lot of sort of natural experiments going on. I would love to see AMDA and our profession advocate for some funding for evaluation of what's working and what's not working. Because we're guessing. And so much of what we're seeing right now is we're trying things, and if a particular facility tries something and stays COVID-free, we say, okay, it worked. And that's an anecdote, but I'm not sure it's evidence. And it would be great if we could actually develop some. And that would be my ask. Let's advocate for that, for some resources applied to developing an evidence base.
Okay, Chris Laxton, if you're on the phone, on the call, make a note. I think that I couldn't agree more. Kathleen and Ritu, what are your asks or wishes?
I have to say that I think I appreciate Chris being in the press and making statements for us. I have reached out to Chris, I think, on several occasions, and I think I'm basically a clinician. I'm not a researcher, and I'm really boots on ground, and I'm also a leader, considered a leader as a medical director. So I really would want advocacy, and that I think I saw with AMDA. I was really happy. We made that leadership group, and we had a voice. We were able to exchange ideas. I was able to win. I think that was what was the biggest ask for me, and I think it was fulfilled. If we can create a certain, I think if we can learn from all of us from different states, and I know that it cannot be all same in all states, and even in New Jersey, it cannot be all the same. But putting all of these things together so we all have it, if come fall when we have a second wave, that we are all better prepared would be a great ask for me. So, compiling all of this and into something that we can just jump on and take it from there, that would be my ask.
Great. Kathleen, 1 second. No, 1 minute. You got 1 minute.
Well, no, I mean, I echo this. I think, this like forums like this to synthesize in learnings across states and to increase lines of communication among states. There is a lot of natural experimentation going on. And I know for about the first month or so, I just had my head down in Indiana with everything that was happening so quickly. And it's just been so helpful to reach out to colleagues across the country and learn from each other.
Yeah, I can really second that, and I really want to thank you all, the participants on the chat, our experts today. This has been an excellent discussion. I had a lot of take-home points from that personally, and really want to thank you for your expertise and also for going the extra mile to advocate for our patients and teaching us. We have learned a few important things, and I just want to highlight a couple. It is important that our voice as medical directors and experts gets heard and provides guidance. And in order to do that, what we've learned from you is to reach out to your contacts, to form, and if you need be, it's okay to be annoying. If you have contacts, really work them. And always keep in mind, it's for the patients, it's not about you. Affiliate or associate and collaborate with the trade associations, the hospital associations as a starter point on going and moving forward. And then also we have now some body of work from you that you can also utilize, and AMDA will provide that. The other thing is then on the ground, really outdoor visits, not necessarily the prison type plexiglass, is the way to go. Be creative, maybe using volunteers, but keep it quite structured, because we all know the threat of COVID is not really gone, and it will stay with us for a while, and it's really up to us to walk that fine balance between giving our patients more quality of life and keeping them safe. So AMDA will continue the COVID Grand Rounds as a peer-to-peer discussion and bring you topics of greatest interest with up-to-date information and how this information specifically relates to our patients. If you have a suggestion for a topic you'd like us to cover, please email us. We will see you all again. Be well, and thank you for all you do.
Thank you. Thank you for having us.
Thank you for excellent moderation.
Yes.
I try. Thanks. It was fun.
Thanks, everyone. That was great.
Thank you. Thank you.
Oh,
Take care.
thank you.
Thanks.